Senate Judiciary Committee. The first thing I'd like to do is just give you an indication of how we're going to proceed today. We are having a special order of business where we are going to have file item 3, SB 128, will be heard first. We're also going to have a special proceeding here, so to ensure that we have a robust and thorough discussion of this bill, we're going to allow both the support and opposition to each have 20 minutes to testify. You decide how you want to use that 20 minutes. And after the main support testimony has concluded, we're going to allow individuals to come up to the mic, state their name, affiliation, and their position in support, and then those, after we hear testimony from the opposition, will allow the opposition to come up and give their 20 minutes, and then individuals after that will be able to similarly come up to the mic, give us their name, their affiliation, and their statement that they are in opposition. We're not going to have extended further discussion after the 20 minutes in support of and 20 minutes in opposition, so that we can have clarity, a good debate, and yet be able to move the proceedings along accordingly. So with that, let's establish a quorum, and Madam Secretary, please call the roll.
Jackson?
Here.
Jackson here. Vidak? Here. Vidak here. Anderson? Hertzberg? Here. Hertzberg here. Leno? Here. Leno here. Monning? Here. Monning here. Wykowski? Here. Wykowski here.
A quorum is present. First, before we proceed, the committee must officially adopt the committee rules. So moved by Senator Leno. Any discussion? That's what I was afraid of. Nice to see you, Senator Hertzberg. All right. Any discussion? All right. Seeing none, Madam Secretary, please call the roll.
Jackson?
Aye.
Jackson, aye. Vidak? Aye. Vidak, aye. Anderson? Hertzberg?
Aye.
Hertzberg, aye. Leno? Leno, aye. Monning? Aye. Monning, aye. Wykowski? Aye. Wykowski, aye.
All right. The rules are adopted. Again, just to complete that last discussion, after all the witnesses have testified in support, if there are any technical questions, we'll take those from the dais. If not, we'll have the opposition come up, ask any technical questions we might have at that point, and then open it up for members to engage in a full discussion on the issues. So without further ado, again, I'd like to invite everybody, or welcome everybody here, invite us to proceed after noting that file item 8 on the agenda, SJR 5, has been pulled at the request of the author, so that will not be heard. Let's take the 2 consent items so that we get those out of the way. 2 consent items, SB 244 and SB 646. Is there a motion? So moved. So moved by Senator Wykowski. Madam Secretary, please call the roll.
Jackson?
Aye.
Jackson, aye. Vidak?
Aye.
Vidak, aye. Anderson? Hertzberg? Aye. Hertzberg, aye. Leno? Aye. Leno, aye. Monning?
Aye.
Monning, aye. Wykowski? Aye. Wykowski, aye.
All right, we will, that's 6-0. We'll leave that on call for the absent member. And now we will turn to our special order of business, file item 3, SB 128, by Senators Wolk and Monning. And I would appreciate it if we have an official photographer or someone at least who has asked permission to take photographs, as long as they are without flash. We would ask that there be no other photography so we can all concentrate on this very, very important issue. So without further ado, Senator Wolk.
I would like to begin first by thanking you and your staff for working with our staffs on this bill. We are accepting all the amendments as reflected in the mock-up as author's amendments, with an additional change to one of the amendments on page 12 in the mock-up to clarify that a healthcare provider cannot enforce a policy prohibiting participation in this act against an individual or entity that has not received proper notification of the policy. We are also committed to continuing to work with the opposition on their concerns. We also have another, just want to clarify that there is another amendment, and that is to add as principal co-author Assemblymember Luis Alejo, who is the chair of the Latino caucus.
All right, so noted.
Thank you. Madam Chair and members, death comes to all of us. We prefer not to think about it, but if we do, we might prefer to die in our sleep at a ripe old age after a full and rich life, surrounded by family and friends with no lingering illness or trauma. But for many, the end comes in a very different way. There can be terrible pain and suffering. There can be an agonizing descent into physical and mental deterioration. Many of us have experienced this trauma with a friend or a relative. My own personal story is certainly not unique. I was 17 when my young, vibrant mother ended a 3-year struggle with metastatic breast cancer. It was brutal. Sometimes the pain could be controlled, but too often it could not. Despite heroic treatment efforts, the suffering was prolonged and unbearable for us and for her. It does not have to be this way. SB 128 would establish the End of Life Option Act in California. The law would give California adult residents who are in the end stages of terminal illness and who are mentally competent the option to get a prescription from their physician which will allow them to end their lives painlessly. We believe that this voluntary option is a compassionate addition to the existing continuum of care that may be used by modern medicine at the end of life, such as hospice and other palliative care. 2 physicians must confirm the prognosis. There must be 2 verbal and 1 written request witnessed by 2 others. A waiting period of 15 days must pass before the doctor writes a prescription. This practice, called aid in dying, is already recognized in other states for 17 years in Oregon, 7 in Washington, more recently Vermont, Montana, and New Mexico. There's been a dramatic change in public opinion. 2/3 of Californians now support this approach, including majorities from every demographic subgroup, including physicians. All major California newspapers and many public officials, including most recently Senator Dianne Feinstein, have endorsed this bill. A major reason for the change in public opinion over the last decade or so is that we have 17 years of experience, of evidence, of actual data and research readily available to all from the state of Oregon on the internet. The fears of the opponents that were voiced at the time that there would be abuse or concern or coercion of the elderly or the disabled, neglect by unscrupulous health plans or caregivers have proven unfounded. In 17 years, 1,327 have obtained a prescription. 40% do not use it. Simply having the prescription is in itself a source of relief, knowing that if the pain becomes unbearable, they will not have to suffer. One of the reasons that this law has worked humanely and safely, without abuse or lawsuit, are the comprehensive safeguards and the protections that are built into Oregon law. Our bill has these safeguards and more. My joint author and colleague, Senator Bill Monning, will now describe those safeguards and protections to you.
Thank you, Senator. Senator Monning.
Thank you, Madam Chair. Thanks to my colleague and friend, joint author, Senator Wolk. I also want to thank you, Madam Chair, and your staff for your excellent work and engagement with our respective staffs and assistance in making this a stronger piece of legislation. I also want to thank the members for your attention today, and perhaps most importantly to our witnesses, many of whom have traveled many miles, and others who are facing other big challenges in their lives and have chosen to be with us today. I am going to focus on the safeguards that are built into the bill As Senator Wolk mentioned, we build on the experience from Oregon, but we believe we've added more fortifications and protections because of some of the unique demographics in the state of California. Again, only a terminally ill adult who resides in California may request and obtain prescriptions from their physician for medication that the patient has the capability to self-administer. Participation in this law is completely voluntary. A person may not qualify solely because of their age or disability. Two separate physicians are required to confirm the patient's prognosis of 6 months or less to live, and that the patient has the mental competency to make his or her own healthcare decision. 2 oral requests are required to be made by a terminally ill patient to a physician, a minimum of 15 days apart, in addition to 1 written request with 2 witnesses attesting to that request before the prescription is written. Patients maintain the right to rescind their request for the medication at any time. The medication must be self-administered, as I mentioned, and safeguards against coercion of patients by establishing felony penalties for coercing or forging a request are a part of the broader oversight and safeguards built into our legislation. The attending physician is required to discuss feasible alternatives or additional treatment alternatives with the terminally ill patient, including but not limited to comfort care, hospice care, palliative care, and pain management. So some have suggested that we're pushing this as an alternative to hospice care, palliative care. That's not true. In fact, we think this bill will help advance greater awareness and participation with existing end-of-life options in treatment and care. Physicians, pharmacists, and healthcare facilities are protected from civil or criminal liability and from professional disciplinary action if they fulfill a terminally ill, mentally competent individual's request. Participation by doctors, pharmacists, and healthcare facilities, including certain hospital systems, their participation is totally voluntary. The essence of this bill is volitional will of a patient and voluntary participation. We see the underpinning of this being the primacy of the physician-patient relationship. No insurance policy may be conditioned upon or affected by a person choosing to request aid in dying medication. A policy can't discriminate if somebody exercises the option or if they choose not to exercise the option. This includes both a medical insurance policy and a life insurance policy. In essence, members, this bill is designed to keep pace with other states that have already recognized this as a resident's right in their states. We seek to establish a fundamental human right that respects first and foremost the autonomy of a terminally ill patient within what is a decision they've had no control over. That is the limited life remaining because of an intervening critical illness or disease, that within that existing limited lifespan of less than 6 months, the autonomy and the right to determine, if they choose, a compassionate transition. That's the essence of this legislation. And members, it's now my honor to introduce as the first witness in support, with the permission of the chair, Mr. Dan Diaz. He's the widower, the former husband of Brittany Maynard, and he will describe their family's experience in having to move to the state of Oregon to seek the type of option that we present to you today. Thank you.
Thank you, Senator Monning. Good afternoon, Mr. Diaz. Thank you for being here.
Good afternoon. Thank you. My name is Dan Diaz, and I'm the husband of Brittany Maynard. My wife died on November 1st from a brain tumor. We live in California, but we had to move to Oregon in order for her to have a peaceful death because our home state of California has not yet authorized medical aid in dying. Palliative care and hospice were not able to prevent or appropriately manage the pain and symptoms that Brittany was suffering from and the worsening symptoms that were coming her way. She would have gone blind, lost motor function, cognitive function, become paralyzed, and eventually tortured to death by the horrible things that the brain tumor would have done to her. Those are the realities of what she would have to suffer through, and it was playing out every day a little bit worse. For 17 years, the laws in Oregon have allowed a terminally ill, mentally competent person to take control of their own dying process and decide for themselves the amount of suffering they may have to endure, and if at all, they need to utilize this end-of-life option. I emphasize that word, option. Brittany's message was simple. Only the individual patient can make this decision for himself or herself. Not a political group, not a hospital, not a religious organization. Only the individual can decide this. Brittany decided for herself. She harmed no one else in the process. The strength of this law is that it provides that option to the person. It is an option that the person has to apply for and qualify for under stringent guidelines and safeguards. Brittany wanted to live, but it was only after being approved for the medication that Brittany was able to focus on living life. She no longer had to be consumed with the overwhelming fear of the terrible death that would otherwise be coming her way if the tumor was left to run its course. Do you understand fear? The fear of dying in a horrific way, if you think about that, that is something that would become all-consuming for anyone. But my wife took that control back from the brain tumor. She then was the person calling the shots regarding her own destiny. Think about the relief that that brings to a terminally ill person. For my wife, to be clear, this legislation was simply a last resort. When we were told that Brittany only had 6 months to live, we continued to search for any and all treatment options that were out there to try to combat the brain tumor. But Brittany also decided it was time to move to Oregon in case she would need to utilize their aid in dying law. She was very concerned about qualifying for the program because it is a rigorous process. Once Brittany began the process in Oregon, the doctors took great care in explaining all of the different treatment options for her. They took great care to make sure Brittany had everything necessary so she could make informed decisions. Brittany felt very secure and protected throughout the entire process. One final point, and Brittany and I discuss this a lot, the current system in California is one that is more susceptible to abuses, coercion, family influence, all of the things that the opposition talks about. Those are more likely to happen under our current system. Currently, a person's final days, many times it's handled behind closed doors with the administration of certain medicines, typically morphine. And there's no way to know how much influence is coming from over-anxious family members, and if the vulnerable members of society, the elderly or disabled, if they are being abused or ignored in the process. The passage of SB 128 creates an open and the light of day environment where the patient is heard and listened to. My wife spoke up, and it was immediately clear to her family, her doctors, and everyone involved in her case that she was the one in control of her own dying process. That is a situation that does a better job of protecting the members of society that need protecting. My time is up, but please, if there's any questions, ask me the details of how Brittany and I could have stayed in California, because we had planned that out too. I thank you for your time, Senators.
Thank you very much. Next witness, please.
Madam Chair, members of the committee, my name is Ben Rich. I am the UC Davis Alumni Association Endowed Chair of Bioethics. I'm here in my individual capacity, and my views do not necessarily represent that of the UC system or the UC Davis health system. SB 128 is aptly entitled the End of Life Option Act. It permits a physician to positively respond to the request of a terminally ill, decisionally capable person for a prescription which, taken as directed, will enable him or her to determine the time and manner of an imminent and inevitable death. Those who maintain that this is a euphemistic and misleading term for physician-assisted suicide failed to acknowledge the significant transformation in attitudes and perspectives among many healthcare professionals over the last 20 years. The major professional organization for hospice and palliative physicians, the American Academy of Hospice and Palliative Medicine, has taken a formal position of studied neutrality on legislation such as SB 128. However, they have unequivocally adopted the position that patients who utilize this option should not be reflexively labeled as suicidal, and that physicians who respond to their requests after confirming decisional capacity are not assisting suicide, but rather respecting the patient's autonomous decision on how to ensure a peaceful death. The American Psychological Association notes, and I quote, "It is important to remember the reasoning on which a terminally ill person whose judgments are not impaired by mental disorders bases a decision to end his life is fundamentally different from the reasoning a clinically depressed person uses to justify suicide." Oregon provides more than 17 years of experience with physician aid in dying. It has been, by all reasonable evaluative criteria, a remarkable success. For this very reason, prominent national healthcare organizations, perhaps most notably the American Public Health Association and the American College of Legal Medicine, have taken official positions in support of aid in dying legislation. The membership of the American Public Health Association in particular consists of professionals who are most qualified to assess data and studies concerning public health, and they specifically reference the Oregon data as strongly supporting the proposition, and here I quote them, "Patients are not put at risk when a carefully crafted law is in place," close quote. In debates about the range of acceptable palliative options of last resort, those who oppose this particular end-of-life option assert that in genuine cases of unrelievable suffering, patients can secure sedation to unconsciousness. However, current clinical practice guidelines for palliative sedation impose upon a terminally ill patient a heavy burden of persuasion that their suffering is both unrelievable and unbearable. Moreover, although touted by some as an ethically preferable alternative, when offered palliative sedation, some patients reject it on the grounds that not only does it violate their sense of a dignified death, but it would subject their loved ones to a prolonged and distressing death vigil over their unconscious body. SB 128 supports the ability of terminally ill Californians to orchestrate the end of their life at a time and in a manner that respects their integrity and their personal values. The spirit of this bill is entirely consistent with the perspective of our own California Supreme Court on the proper role of public policy with regard to individuals who are confronting death, and I close by quoting them. "As the quality of life diminishes because of physical deterioration, the state's interest in preserving life correspondingly diminishes. The role of the state is to ensure a maximum amount of individual freedom of choice and conduct. No state interest is compromised by allowing an individual to experience a dignified death rather than an excruciatingly painful life." Thank you very much for your attention.
Thank you, sir. Next witness, please.
Good afternoon, Chairman Jackson and honorable members of the Senate Judiciary Committee. It is a pleasure to be here with you today. My name is Christina Simons. I have 4 children, ages 11 and 5, and my good friend Crystal is here with me today. I do not want to die, but unfortunately, amyotrophic lateral sclerosis is killing me slowly. Doctors say I only have a few months to live. I will continue to fight until the end, and nor will I take that on. But since they've advised, it's been easy to live in denial until the symptoms are unarguable. So, I'm told my breathing, unbeknownst to me, has decreased significantly. And now that my voice has been affected, I know it's real. I do not want to live my last days in a wheelchair, fully paralyzed, connected to a breathing machine. To me, that is horror, just a picture of horror. So like Brittany Maynard, my family, we call ourselves a six-pack, there's 6 of us, picked up and moved to Oregon 2 weeks ago, where I can now start the process to obtain the medication. The thoughts, the time wasted obsessing about what I'm facing and what this disease will take you through, prohibits my ability to just enjoy life. Again, it's not for everyone. I can only tell you for me that I love California. I didn't want to leave this state, but I don't have time, unfortunately, to wait around to see when this is going to happen. So, the medication I know will bring a peace. I don't have to worry. When it gets to the point where I've had enough, I'll have the freedom to make that choice. It was very disrupting having to go to Oregon. We sold our home. It was very emotional. My husband left his job in the Ventura Police Department, early retirement. We uprooted the children, and we are in the process of finding new doctors to take my case. Again, this move has brought me an incredible peace of mind to know that I don't have to face what they say is to come. Our children do not know that I am dying. We tell them information as necessary. They're having the time of their life running wild in Oregon. But all my children knew Brittany Maynard from her courageous story, and they know about the movement of having the right to die with dignity. And they know what the prescription is. So when the time is right, and when I face that time, we'll explain. But as of now, it is unlikely this bill will become a law before I die. But as my children get older, they'll understand why we had to move to Oregon. I can't imagine not having the option to end it. I can never go through that process with my children having to endure that. So they will know our sacrifice of leaving our home state and my doctors, and they will have played a small part in making the difference for dying people in our home state of California. Thank you.
Thank you very much. We appreciate your being here and your very moving testimony. Thank you.
My name is Dr. Myron Turbo. Good afternoon, Madam Chairman and members of the committee. In addition to being a board-certified medical oncologist, I was certified in hospice and palliative care. I am a founding member of the Association of Northern California Oncologists, ANCO, and a former past president of that organization. I served as a hospice medical director for over 25 years. I'm a founding member of the American Academy of Hospice and Palliative Medicine. I served in the clinical faculty of Stanford University School of Medicine for over 25 years. Although I'm a retired physician, I still teach at Stanford, as well as lecture on end-of-life issues. In the almost 40 years that I took care of patients with cancer, I saw 200 to 250 patients each year. Of the approximate 8,000 patients I saw over my career, approximately 50% survived and 50% did not. I accompanied approximately 4,000 patients on the final journey of their life. Although I was skilled at palliative care and I could provide all the advantages that hospice had at its disposal, some patients nonetheless suffered and would have welcomed what Senate Bill 128 can provide to them. Aid in dying under this law is not a replacement for palliative care or for hospice. It's an additional end-of-life option to be considered by the patient and by all physicians, whether they be a hospice doc, palliative care specialist, or an oncologist. As a medical student, I was taught, do no harm. In patients with a terminal illness, the harm is done by the underlying illness. This law is directed at relieving the suffering, not doing harm. Physicians are trained to be healers and to cure disease. As an oncologist, I learned some patients cannot be cured. Some people's problems just can't be fixed. Hippocrates, the father of Western medicine, taught his students in ancient Greece, cure sometimes, comfort always. From my perspective, comforting a dying patient and relieving his or her symptoms and the suffering is the highest form of healing. Oregon enacted the Death with Dignity Act in 1997, and the law has worked well. The passage of that law has improved end-of-life care for everyone in that state, and I truly believe that the passage of this law will improve the end-of-life care for all Californians. First, it will increase the frequency of the end-of-life conversation that patients have with their physician and their family. Just as in Oregon, it will increase participation in hospice and will bring peace of mind to many patients with a terminal illness. As you have heard, 35 to 40% of Oregonians who fill prescriptions do not ingest the medication and they die from their underlying disease. It is my belief that merely having the medication on hand in their presence will bring peace of mind and solace to patients and their families. I encourage this committee and the California legislature to pass the End-of-Life Option Act. Thank you.
Thank you very much, Doctor. That is 20 minutes, almost to the penny, or I should say the second, and to the penny as well. Are there any kind of pointed technical questions at this point? Otherwise, we can call these folks back to have a full discussion. So if there aren't any technical questions, what we'll do is thank you all for your testimony. Please be available once the opposition has a chance to present their case, and we'll have a robust discussion, I'm sure, at that point in time. But thank you so much for your testimony. And now, if we could have those members of the public, if they would come up to the microphone, if they would like to simply give us their name, their affiliation, and they're positioned in support. I'm assuming at this point, we're just going to hear from those in support, name, affiliation, and your support for the measure. And thank you.